So I'm Gia. I just finished my Master of Health Sciences under supervision of Gary. So I'll be very honored to share with you part of my master's project, Young Onset Dementia, investigating timelines of admission to age residential care and health outcomes. So I'll first go into introduction of young onset dementia and then cover some literature gaps and what's my aims, methods I've used, results I've obtained, and also the conclusion we've made. So what is young onset dementia? It was previously known as presenile dementia about 10 years ago, and then they've changed to younger onset dementia, early onset dementia, or younger people with dementia. But currently, to prevent any confusion between early onset dementia and early stage of dementia, which we know it's totally different thing, the current preference term is young onset dementia. And it's young onset dementia is defined as people with dementia aged 65 years and below. So that is actually an arbitrary divide. So that is the historical retirement age for in terms of the psychosocial impact, but there's no neurobiological significance. So here's the epidemiology in New Zealand. So Ryan et al. Did an prevalence study in the whole New Zealand, and A2 Fonseca et al., his team, did the incident study in Waikato cohort. It's not surprising to find that age 45 to 64 people actually have an increased prevalence and incidence compared to 30 to 64. And ethnicity-wise, Maori actually have the highest prevalence and incidence, which is actually same as the research that's stating Maori and Pacific peoples have a higher burden of dementia risk. So what's the gaps? We're actually lacking of health outcomes research in young onset dementia in New Zealand. And also the prognosis of the course of young onset dementia is actually lacking in the whole world. In fact, Baker et al. Did their first study on predictors of the time to institutionalization in young versus late onset dementia in Australia, and they found that the time of young onset dementia patients being institutionalized is 9 years as opposed to late onset dementia, which is 4 years. Which brings us to the aim. What is the time to institutionalization for the Waikato patient cohort after the date of diagnosis? And also the second aim, what's the health outcomes before and after institutionalization? So in this project, I've used the patient cohort from the incidence paper I've talked about before, and they have included in inpatients aged 30 to 64 with a coded diagnosis of dementia, and also outpatients referrals aged 30 to 64. They have included 64 patients in total. And we have access to InterRAI data set at least 5 years post-diagnosis, which is up to 31st of December 2021. And I have recorded some of the answers for statistical analysis purpose. And from Fonseca to the incidence paper, I've got the demographics and the diagnosis there. And then I have come up with the age assessments for each patient, for each assessments. And thanks to E2 who went into the clinical notes to dig out the date of diagnosis, and he found 3 unmatched NHI, and through the data linkages, I've found one incorrect date of birth, which means the patient have the diagnosis at 80, which brings him to late onset dementia. So we're down to 60 patients for this project. So this is the timelines for the time to institutionalization survival plots from date of diagnosis. The blue is the long-term care. That means the first line, the first patient, hypothetical patient were admitted. So we use the first assessment, the first LTCF assessment date as the date of admission. The next two lines, you can see that they only have HC, the home care, or the contact assessments. That means they are not admitted. So we use the sensor date as 31st of December 2021, they're being not admitted. And in total, the patients included in the curves are 56 because we have 4 already admitted in the residential care before diagnosed with dementia. And then for ethnicity, we have got 2 less because the response is unidentifiable. And this is the test we use to compare the pre and post institutionalization outcomes. So McNema or McNema-Barker test for those with more than 2 categories. And so this is a paired binomial, a paired non-parametric data. As we can see that we tried to use the last home care and the first long-term care assessment to compare the health outcomes. But if we can see the third line, it's actually less than days, the assessment state, which means InterRAI says InterRAI, we're doing very good job. So we actually made it 6 to 18 months from the first long-term care to the next long-term care. So anything that falls before 6 months, we are not taking it. We use the first one that lies between 6 to 18 months for them to acclimate into the aged care. And then we have got 29 patients for this analysis. So these are the health outcomes compared in the McNema test. Some of them you might feel very familiar, and I love the brain there. It took me one day to do this. So, results. Here's the patient demographics, 35 to 67. Our patient cohort is just 35 to 67 age. So you might find it weird because I said 65 and below as the cutoff point for young onset dementia, but we included 67 because it's the symptom onset before 65. And 35, it's very young, about my age. Well, and a mean of 59.6, not too bad. So more than half are actually males. So males, be concerned. And only a quarter patients are Maori. And we only found 13.3% Alzheimer's patient, which is quite different from that in late onset dementia. And here's the curves, time to institutionalization from date of diagnosis. Generally, half of the patients were being admitted about 4.5 years after diagnosed. And then if we change it, if we stratified it to with age greater than 60, they are actually admitted slightly earlier, about 3 years and 4 months, but it's not statistically significant. By gender, females actually get admitted earlier, but 3 years and 8 months. Again, it's not statistically significant, maybe because we only have 56 patients to plot. And then ethnicity-wise, non-Maori actually gets into the institution about 4 years, so slightly earlier than the cohort. Again, not statistically significant. Alzheimer's disease, very much earlier, about 2.5 years. Close enough, again, not statistically significant. And I've plotted a timeline. We can see that general cohort, they are admitted 4.5 years, and then non-Maori. And then, as I said, Alzheimer's dementia patient, they are much earlier. So here's the health outcomes that are significant. Not a whole lot. And I apologize for my mistake. And the hospitalization is none, no hospitalization within the last 90 days. And then the second one will be hospitalization within 90 days. And the last one will be now in hospital. So we can see that after institutionalization, they are actually decreased in smoking, maybe because they can't. And then their health actually become more stable. As we can see, chest is actually better. And then they actually exercise more, maybe because they were forced to. And then hospitalization, we can see now in hospital, there are none of them. And no hospitalization within the last 90 days actually increased. So that's better, which actually is better, no smoking, more exercises, more stable health, and then less hospitalization. It all works. So what's our conclusion? It's actually the first natural history of young onset dementia research in whole New Zealand, and the first health outcomes comparison before and after institutionalization globally. Well, we found 4.5 years of after diagnosis after diagnosis to institutionalization, which is, sorry, nothing there, which is actually which is quite consistent with Baker et al. If you remember, it's actually 9 years from symptom onset. So we actually have an average delay of diagnosis about 3 years in young onset dementia. So which means our time is actually consistent. So that's all from today from me. I'd like to close my presentation with a whakatauki. I can't really see it from here. Waia te mataranga e oranga mokoto. Please correct me if I'm wrong. Seek after learning for the sake of our well-being. I think that's why we are all here today. I'd like to thank my supervisors, Gary, and my co-supervisors, Bridget and Claudia, and also thanks Ito for his data. Thank you.